brief introduction. I think we've, for many decades, we've managed diabetes in a similar way in terms of as diabetologists, we focused on hypoglycemia. We've had algorithms that have allowed us to try and achieve a certain A1C target. And so the ADA and the ESD, the Europeans and the Americans, have come together to produce consensus. And this was the first one in 2006, which followed that format. And really, we only had insulin, metformin, and the TZDs. In 2012, that was updated, and you can see metformin was very positioned as the first-line treatment, but then it was very much an algorithm as what next after metformin with the SUs, TZDs, TPP4s, and the GLP-1. So then we had the incretin-based therapies, as well as insulin, and basal insulin was preferred. And the discussion was which combination was used. And even up to 2015, really very little had changed, apart from we then had the SGLT2s then positioned in that what next after metformin. But since 2015, of course, the world has changed very significantly in terms of glucose-lowering therapy, and this FDA requirement for these large cardiovascular outcome trials has given us a huge amount of evidence now in our patients with type 2 diabetes. So when we looked at the 2018 update, we had to do a much more thorough review of the literature. Before, the consensus really was expert opinion, and we didn't feel that was appropriate in this modern world where there is so much evidence now. There is a much greater focus on lifestyle interventions. I don't have time to talk about it very much, but weight loss, bariatric surgery, obesity management, and physical activity are really important, and we've forgotten their importance in the management of type 2. There's a deliberate focus on patient-related issues and self-management in patients with type 2 diabetes, which can have a major impact on any success. We can have the best drugs in the world, but if patients don't take them or don't understand the requirement for them, we will fail. And we also need to consider therapeutic inertia and medication persistence. And I know my colleague from Leicester, Kamlesh Kunti, has been at this meeting also talking about that. But the big difference that we said, I think, was that there are different choices now of different agents depending on the clinical characteristics of the patient sitting in front of you. And we've shifted really the focus on the patient. The person with diabetes should be at the center of their care. And the goal is not to reduce glucose for the sake of reducing glucose, but to really prevent complications and to use therapies that may confer life-changing benefits on patients by reducing the burden of complications. And particularly now we have agents that can reduce the burden of macrovascular disease and also to optimize patients' quality of life. And that process starts around this decision cycle where you have to assess the characteristics of the person sitting in front of you, particularly with regard to comorbidities, to make those decisions. We also highlighted the importance of empathetic patient-centered care, and that you need to consider the healthcare system that you're working in and the personal, social, and cultural context of the patients that we're treating, and the contribution of the options that we advise in terms of the benefits, harms, and costs, because we live in a world where cost is also very critical. The other aspect is the shared decision-making to inform a management plan, because that can improve the quality of the decisions that we and our patients with diabetes make. And in the modern world, it's an ethical imperative to support patients to make autonomous decisions. We also highlighted the importance of self-management education, because in this world of evidence, actually, the evidence of from structured support and self-management programs is as good as the drugs. So it's shown to reduce glycemic control, reduce hospital admissions, improve knowledge, And also there are now meta-analyses showing reductions in all-cause mortality. So the key change, I think, is that this choice of glucose-lowering medications, because remember this is a consensus about the management of hypoglycemia, should be based on patient preference and the presence of established, particularly comorbidities such as established ASCVD, as well as other factors such as hypo, weight, and cost. And so this is the algorithm that you will have seen in the 2018 document, which calls out now not the same algorithm in all patients, but the first priority is to call out those patients with established ASCVD, chronic kidney disease, or heart failure. And I'll focus in the second part of my talk onto how this bit has been influenced by the recent trials. Because remember, when we published this in 2018, we really only had LEADER, EMPA-REG, and a few of the other studies, such as ELIXIR, that are published. In those patients without established ASCVD or chronic kidney disease, there are other factors that need to influence your choice. Is there a compelling need to minimize the risk of hypoglycemia? Is weight gain and losing weight the ultimate priority? And for many people, cost is the thing that makes the biggest decision to their choice or access. So just to concentrate on the new data. So we've had, since we published our data in 2018, a huge amount of new evidence. DECLARE, Credence, Carolina, Pioneer 6, Rewind, Verify, and also more data now around the combination of SGLT2s and GLP-1s. And so I'll cover each of these just very, very quickly. So first of all, what about weight loss? And what about the combination of SGLT2s and GLP-1? So as you know, in patients in whom you need to lower A1C, but you're worried or you want to maximize weight loss, then we suggested two classes, the GLP-1s and the SGLT2s. The GLP-1s are quite heterogeneous across the class for weight loss, with the best data with semaglutide and really quite modest data, for example, with lixisenatide. The SGLT2s are more similar than they are different in terms of their impact on weight. But also the discussion, we'd suggested that you could use the combination, although there wasn't a huge amount of evidence to support that. We have data from Duration 8, where the combination of a GLP-1 and SGLT2 was compared to each alone, and there did appear to be some benefit, particularly in terms of added weight loss. And we now have these two trials where, on a background of SGLT2s, GLP-1s were added, either dulaglutide here, where the added value above placebo was about 1 kilogram, and here semaglutide, where there was a greater added value to adding to an SGLT2, and there were a number of different agents in the background therapy of an additional 3.8 kilograms. There's been a recent meta-analysis looking at the combination of GLP-1 and SGLT2, looking at the studies that are available, and you can see this is the impact on A1C, so about a 0.7% reduction. Although you can see, again, there's some heterogeneity. Here's the semaglutide study here, which has the best evidence. And again, with weight loss, about a 1.7 kilogram weight loss across the trials, but again, some heterogeneity with nearly 4 kilograms with the combination. So in terms of A1C and glucose lowering, there is some difference across the class of GLP-1, but we do have across the class good evidence now, or reasonable evidence of this combination, albeit it's a quite expensive combination. What about the SU DPP-4? And I think it's true to say that the DPP-4s, whilst they remain useful, we don't have data in terms of cardiovascular or renal protection. We do now have this data compared with glimepiride and linagliptin, showing no difference. Really, I think very reassuring for patients in terms of sulfonylureas not being harmful and being a similarly in terms of cardiovascular outcome trial to the DPP-4 inhibitor. And we already know that we get much lower rates of hypoglycemia with the DPP-4 compared to the SU. But I would remind you that the rate of severe hypoglycemia was pretty low in these studies. What about combination, early combination? In our initial consensus, we talked about the need for early combination, particularly in those patients whose A1C was 1.5% above their target. We have this single study now. It's an important trial, 2,000 patients, early diagnosed with relatively well-controlled A1C of this combination with metformin and the DPP-4 inhibitor vildagliptin. Showing a reduction in the probability of initial treatment failure. So I think this is an important study, but we don't really know what we would have seen if we used different types of combination, i.e. with a GLP-1 or an SGLT2. But I think certainly in some patients, early combination therapy is looking increasingly attractive.